say good morning and welcome. Thank you for coming to our first TUBB4A family webinar hosted by the Kinslow TUBB4A Foundation. I am Sarah Marta, and I, along with Daphne Grascuas-Prado, founded the Kinslow TUBB4A Foundation. So we are so excited to be able to come together as a community of families, advocates, and experts who are all bound by a shared mission to learn, to support one another, and to push forward in our fight against TUBB4A-related leukodystrophy. This week, we received the heartbreaking news of the loss of another child to this cruel disease. To Noah and to all the other children who have left us too soon, we honor their lives and their legacies. So I would like to invite everyone to join me in a moment of silence to remember and reflect on their beautiful spirits. Please also keep a lookout on the parents page for information about lighting up social media next Friday in honor of Noah, because together we can really amplify his memory and raise awareness for this devastating disease. Today's webinar will provide valuable updates and insights for families of every stage of this journey. We'll start by hearing from representatives of TUBB4A foundations around the world. This will be followed by a presentation by Dr. Gavassi, and then we will have a Q&A session. So feel free to jump in at that time with any of your questions that you might have. And then we will end with updates and initiatives from the Kinslow TUBB4A Foundation, where we'll share what's on the horizon for our community. So thank you again for being here, for your resilience, and for your commitment to building a future filled with hope. Jose, we will start with you.
Jose,
Okay.
you got to unmute.
Hey, Zoe, could you unmute your mic?
I was silenced, right?
Yep.
Now we can hear you.
Okay, great. It was a silent movie so far. Great. I'm José Torres Vicente. I'm one of the founders of the Spanish Foundation, Fundación Leukodystropia TUBB4A, as you can see. I'm also the secretary of the foundation. We created our foundation a couple of years ago in 2022. Our mission is, as you might guess, is to find a treatment or a cure for this disease. We are trying to support the research and to give visibility to the disease, and also we are focusing on improving its early diagnosis. We are so far 10 known cases in Spain, but it's hard to know if there are many others because, as I said, there's no early diagnosis and genetic diagnosis is not available for everybody. We are focusing our activities on financing the research on the disease. We have signed a collaboration agreement with a hospital here in Spain, in Barcelona. It's Hospital Sant Joan de Déu, which is also partnering with TUBB. We are financing one global project in which Hospital Sant Joan de Déu is taking part alongside with TUBB. We also are giving support to families. We are giving information in these early stages of knowing about the diagnosis and to give some emotional support and administrative guidance to those families which arrive to the foundation with the diagnosis, and we are also trying to spread awareness because, as you know, there's no awareness of this, mainly of the leukodystrophies, but of our leukodystrophy it's even more unknown. And now we're trying to get more and more resources. We are selling merchandise. We are organizing charity events. We are getting more and more private donors, and we also have got some corporate awards and corporate donations. Apart from the 4 families that we created the foundation, we have also the collaboration and the support of other families here in Spain. That's what I can tell so far of our very young foundation. Thank you.
Perfect. Thank you.
Thank you.
Michelle, we will move on to Foundation to Fight.
Great. Thank you, Jose. Great presentation. How are you? Foundation Fight HABC, a little bit background about us. We've been in existence since 2015. We're the first formal organized advocacy group for this condition. My daughter lives with it. She's 19 years old now. We started out at age 8. So we've been living this journey for some time, as I know many of you are. We are inspired, obviously, by our daughter. We have a board of directors that are comprised of a diverse group of not only patients and family representation, but also non-patient industry experts. We have a scientific advisory board that advises us on genetics, research, neurology, and we have a long-standing relationship with various leukodystrophy and rare disease advocates. Our focus has been on research and will continue to be on research. We were very much part of the early part of CHOP's research, and I know, Francesco, you're going to be talking a lot about the natural history study, which we've financed the original rollout of, and now NIH financed, which is great. And continuing to support various different events, scientific symposiums, families events, which one is coming up in June in Chicago, which I hope folks can join us. We'll have a separate session there basically for the families during that conference. And excuse me, we continue to support gene therapy for AAV gene therapy. Excuse me. To date, we have raised approximately 100,000, and our large amount of our work is towards the AAV gene therapy research, which is ongoing. And then, of course, we're continuing to support families as well as various conferences, and then also other initiatives that we're working on. Let me talk a little bit about the gene therapy, which I think is important here because this is the permanent, hopefully a permanent cure for this condition. It's invasive in terms of the actual therapeutic, so it takes a lot more research and a lot more time involved in it. We're working with UMass Chan Medical School. We've been working with them since late 2020 to develop a vector for gene therapy led by Dr. Gao, who's very prominent and well known in the industry for AAV gene therapy. They've identified lead silencers and AAV vectors that can be expressed in neurons and oligodendrocytes. At this time, the primary concern is working through safety issues, and additional testing is required. So we have starts and stops, just like anything. Right now, we're hoping by mid-2025 to get some good results. But again, we need to determine that there's safety and efficacy in what we're doing. But if it's successful, our next steps with UMass is to move into primate testing within NIH funding. So what we're working on and have been working on is continuing to work with the Syntaptics Bio and the UK Foundation to work towards a FDA clinical trial preparation. We're going to continue to pursue the AAV gene therapy research. We're looking at drug repurposing possibilities, homeopathic support while we wait for a cure, We're continuing to expand our outreach to the undiagnosed patients. Just had another one come forward today, which is great. And we're collecting data as we move forward. We're supporting our families living with it, which I think is extraordinarily important. I'm also working with various different partnerships and family support services that we hope to roll out in the next month or so. And lastly, looking at alternative treatment technologies that might be available. This is our board. This is our advisory board and our foundation board. And if you'd like to contact us, our information is on the slide. Thank you.
Oh, thank you, Michelle. Now, Amy.
Hi, everyone. I'm Amy Sheridan-Hill. Thank you, Michelle. Thank you, Jose. So myself and 4 other HABC parents set up HABC Foundation UK in 2019. As we all know, when you get that shock diagnosis, you just don't know what to do. And we saw that Michelle had set up the US charity. So we thought, why don't we do one in the UK? So we set that up about 5 years ago, which is a few months after my little boy was diagnosed. We started fundraising. Again, as we all know, our main aim, as soon as you get that diagnosis, you're like, how can we cure this? What can we do? So we kind of panicked fundraise, thinking we need to fund the clinicians, we need to fund the research. And we started funding money towards CHOP and towards their research. We soon realised that to get to clinical trial, we're talking millions and millions of pounds. And as a small foundation, that's not going to happen. And one of our trustees, Michelle Teng, who has Sophia with HABC, is a geneticist. And she thought, hang on, I'm going to set up Synaptics Bio, I'm going to set a company up, and we're going to go down that route to get to clinical trials. So that was kind of massive, really. As a small foundation, we weren't going to raise those millions. And Michelle has got a great team together. I think Uwe's on this call somewhere. And yeah, Synaptics are working really hard to kind of move trials forward. So us as a foundation, once we kind of were working with Synaptics and they were moving the trials forward, we then focus more on the families. So we have set up a grant program. So we fund wheelchairs, equipment, things like that for UK families that we struggle getting on the NHS in the UK. And a big thing, as I think Michelle and Jose have touched on, is awareness. We know about 25 families in the UK, but I'm sure there's loads. I can see Debbie on the call, and Debbie lives about 10 minutes drive from me. And we have another family that live 10 minutes drive the other side. And you think, you know, we're so close, there must be so many more than this kind of 200 odd in the world. So we're really trying to raise awareness of TUBB4A, writing to hospitals, asking clinicians to kind of look out for signs and symptoms, and signpost families to us if they do get that diagnosis, because as we all know, that's not a fun place to be, and to have someone that maybe can help support you a little bit does make a huge amount of difference. And I think us having all these foundations across the world is brilliant, and we've kind of got all that support together. Sorry, my dog's going mad because the doorbell's gone. So yeah, I think one of the things I did want to touch on is we're working with Synaptics to put a map together to kind of plot where everyone is across the world, so we can really see where the gaps are in diagnosis. And loads of you have filled out our form, and if anyone hasn't, if they can contact me, I'll send it to them. But it's really interesting. We'll try and share that with everyone at a later point. You can really see where there's countries where there's no kind of diagnosis at all. For example, in the UK, you can really see a big patch in the south and a big patch in the north, and nothing in between, nothing in Scotland. So it really helps, I think, to see where the gaps are and maybe where we can reach out to and kind of see if there are families that need the support. So yeah, that's kind of us. I think I've waffled a bit too much there. So if anyone, you know, wants any support, wants to contact us, feel free. And I just want to say that it's lovely seeing you all, and I think it's great that we've got all these foundations and everyone working together.
Thank you, Amy. We really appreciate that. Dr. Gavassi with the Children's Hospital of Philadelphia has so graciously agreed to come on and talk with everybody. So I'm going to stop sharing my screen and allow him to start because he really does have the bulk of the information and what we are all wanting to learn.
Thank you very much, everyone. So let's see if I can share my screen appropriately. Okay. Do you see the presentation in presenter mode?
Yes.
We can see it.
Perfect. Okay. So, okay. You see the, yeah, perfect. Okay. So today I'm just gonna give you some updates. Well, actually, it's not catching the right line. Let me share it the other way. Okay, it's much better. Perfect. So today I'm gonna present you some updates on the current state of the art when it comes to research with a focus on natural history studies in the TUBB4A related leukodystrophy world. And I've organized it in a number of steps, but if you have any questions, feel free to raise your hand and I will be happy to answer that. If not, I know that there is a pretty extensive Q&A section after the talk, so we can also do that in that specific way. And I apologize in advance. I have simplified some aspects a little bit to make them more clear and understandable, like taking out a little bit of the jargon. Some of that still remains, but I will be happy to explain all the different aspects. So these are my disclosures. I am currently supported by a couple of NIH funding that are focused on natural history studies in different leukodystrophies. And this is the outline of my presentation. So I wanted to give you a little bit of an insight on how this condition was first described and some of the history associated with that, because there is still some unclarity around the expansion of the original clinical manifestation to what is now known as TUBB4A related leukodystrophies. We will discuss a little bit around how the disease, what is the cause of the disease, so the pathogenesis, how it's generated, and then some of the clinical manifestations that this condition has, which you will see they're quite heterogeneous. And then we will go more into the more updated research that now we started to outline some potential cohorts within the overall diagnostic umbrella. And then I will present some aspects of functional profiles that we started to capture in this population through the administration of standardized testing. And not only on that, but also what is the impact of the diagnosis itself on children that are affected, but the overall network also. So the expanded network of caregivers and potentially even more than that. And then I will take a few minutes to present some of the updates on the animal models and some of the therapeutic intervention options that are starting to become available, both in a sense of symptomatic management, but also potentially in the sense of curative interventions. So the condition was first described by Dr. van der Naap in the Netherlands in 2002. And it was described mostly from a radiologic perspective. So I included a couple of the images that were included in that publication. And basically, this was a condition that was originally described in 7 children with different stages of the condition, if we can say in that way, but somewhat similar one to another. And so these were children that were presenting fairly early on, but you see that there was a variability because they were described as having an onset at 2 months of age, but also at 3 years of life. And the onset was characterized by a delayed motor development, which means that the acquisition of gross motor skills was not quite at the level that would be expected in a typical pediatric population. and it was associated with poor vision. And poor vision was not as well described, but included both the inability to fixate and track a target because of the presence of eye movements that are classified as nystagmus, but also potentially challenges in the processing of the images. And then this condition was described as progressive over time with a specific loss of motor skills, potentially more than loss of cognitive skills, even though they were not specifically studied in the specific first publication. And one characteristic that was observed was that there was an MRI pattern, so an imaging pattern that was consisting with hypomyelination and atrophy of the basal ganglia and the cerebellum. So I will explain what these aspects are, but basically hypomyelination refers to the fact that the brain is comprised roughly of two different sections, the white matter and the gray matter. And the white matter of the brain is basically a part of the neurons, so the axons, and the white substance called myelin that basically insulates them. So if you can consider white matter as an insulating tape that allows the electric impulse along the neuronal cells in a way that facilitates the transfer of the signaling and potentially the communication between the different cells. And so the hypomyelination is basically a situation in which we observe that there is a reduced production of this myelin. And then basal ganglia and cerebellum are structures of the brain, overall the central nervous system, that basically were observed as being potentially reduced in size, so with a loss of volume altogether. And this first condition was then described and fell under the umbrella of leukodystrophies. So leukodystrophies are a number of conditions that affect the white matter of the brain, and basically these myelin sheets surround the neurons. So you see this orange cell, and the myelin basically envelops the longer piece of the neurons, so the axons, and basically this facilitates the transmission of the neuronal impulse, the electric impulse, specifically the speed of it. And if there is a reduced presentation of it, then a reduced production of it, then we enter in, we basically diagnose the specific leukodystrophy as a hypomyelinating leukodystrophy. Why this is a condition that happens in this specific way. So a few years after Dr. van der Naap originally described this condition, it was identified a gene that was associated with this specific condition, which was the gene TUBB4A. Specifically was described a variant that was common to multiple subjects, and that we saw in the future it's one of the most frequent variants associated with this condition, even if not the only one. And this genetic variant is C745G on A, that basically causes an amino acidic change that I've included there. So ASP249 ASN. And on the right, I included an image that is coming from this publication that I've included by Dr. Cass-Simon, that identifies the specific place in which this variant is observed. And what is the function of tubulin? So basically beta tubulin, which is the protein that is generated by this specific gene, is a dimer. So there are multiple beta tubulin that come together and associate also with alpha tubulin that are produced by other genes. And basically these proteins generate sort of a microtubule when they assemble, which is sort of like a highway within the cell that basically allows for the transportation of structural molecules that are vital for the healthy life of the cell. And basically, it's also one of the structures that allows and facilitates cell division. And so when these proteins are not as functional, you see that there are a number of functions that are potentially jeopardized, and they are limited to some extent. And so this is potentially what we're observing when we observe some of these hypomyelination, findings. And specifically, TUBB4A related leukodystrophies, and originally HABC, is a condition that is autosomal dominant. So it means that if you every gene is present in 2 copies on 2 different alleles, they're called, within a specific chromosome. And autosomal dominant means that only one variation, only one genetic variant on one of the 2 alleles that is disrupting, and so it's pathogenic, causes the disease. And because of that, typically this condition is de novo, so neither one of the parents have that specific variant, but it's observed only in the child. That's not always the case. There can be situations in which this is inherited, but it's much more rare. And the effect of these variants is typically a toxic gain of function. So here I included the 3 potential options, the 3 potential situations that you can encounter when you have a genetic variant. So you can have a wild type, which means that basically there is no genetic variant, or the genetic variant is not causing a disease. And so the protein is formed and there is normal physiology of the cells. So basically the cells function as well as any other one. When there is a loss of function, basically the protein is not formed, and so the function of the protein cannot be performed. But on the other side, the gain of function is when I have a hyperactivation of the cellular pathways, and so I have too much protein, but the protein is basically too much for the cell to handle, and it doesn't basically organize in a way that is functional. That's what is called toxic gain of function. And clinical manifestations can be quite varied in a way for this specific condition. And we conducted a study that included a substantial number of collaborators worldwide, and this included both collection of data directly from subjects that were enrolled in the clinical trial, but in the natural history study, but also of subjects that were already described in the literature and for which there was enough information to be able to securely identify them as subjects with a diagnosis of TUBB4A leukodystrophy, and that had enough information to be able to start panning out some analysis. And so you see that we were able to include overall 217 subjects, 40% female, 55% males, and for some of them there was not enough information to be able to derive that. About 50% of them were Caucasian white, but so this can potentially present a bias in some of the in the ability of identifying this condition in other ethnic groups in which potentially the condition might present in a slight different way. And if you see, the age of onset is quite early. The median was about 0.71 years. So this is a condition that for the vast majority of subjects has an onset within the first year of life. But if you observe the line below mean and max, we actually observe a big variability. So this is a condition that can present at birth, but also at 12 years of age, for example. And for some of these subjects, we were able to collect enough information to basically evaluate the follow-up of the subject. So basically not only have one shot information about, for example, when the onset of the disease occurred, but also longitudinally, what was the trajectory of the condition? What were potential medical complications that arose? And so you see that we were able to collect follow-up for about 5 years median, but for some subjects up to 35 years of follow-up. And so you start to see how this allows us to be a little bit more precise in how we can identify trajectories, but also potentially some biases that I will address when we will go at that point. The first thing that we tried to identify was what was the first sign or symptom that was observed by either families, by the physicians that were following the children at the time, so typically the pediatrician, or potentially by both at the same time. And so what we observe is that in a substantial amount of children, the first symptom that was observed was a delay in the acquisition of motor milestones. So, for example, a child was not holding their head quite up at the time in which it was expected, or potentially they were a little bit slow in achieving a sitting position that is independent. In some cases, ambulation was delayed. And so that's something that was observed, but it's quite unspecific, non-specific. So you see that it's not something that would potentially raise like a red flag for specifically TUBB4A leukodystrophies. But there are other symptoms that can potentially be associated to delayed motor milestones or independent on their own, such as muscle tone abnormalities. And so typically what you will see is a child that potentially has a little bit of a high tone in the lower limbs, or maybe in the upper limbs, or maybe there is a decreased muscle tone of the neck area or the trunk area. And so you potentially see a child that is a little bit floppy in the trunk and is a little bit tight in the extremities. One other thing that is observed is nystagmus, that are specific eye movements that can present as basically a beating of the eye in the horizontal, in the vertical direction, or potentially circular. And these are involuntary eye movements that are observed typically on the earlier stages. Sometimes it was observed that there was a delay in the cognitive milestone abilities, and cognitive, it's a little bit of a lax term here. So one of the things that was observed more typically was a delay in expressive language, so generation of words, and then a potential delay also in social milestones, so more into the interactivity of the child. We also observed some feeding concerns and failure to thrive, so subjects that were potentially struggling with eating enough food or eating safely food, or potentially managing consistencies of food, for example, needing puree food versus small pieces, or on the other side, potentially challenges with the ability of have an intake of thin liquids. And then in subjects that presented a little bit later in life, more specific cognitive difficulties or encephalopathy. And then there was observation of ataxia, which can present as basically a challenge in the balance. This can be observed both in children that are ambulating independently. And so in that case, what you will observe is having a broader base of gait and a little bit of instability, specifically in the change of directions, but also can be an ataxia of the what is called appendicular ataxia, so more of the upper extremities and the inability of basically coordinate. And then in other subjects, it was observed more of a specific spastic diplegia, so the tone abnormality was not as much diffuse everywhere in the limbs, but it was more specific in the lower limbs. And then you can also observe dystonia, that is basically a movement disorder that is associated with a contraction of all the muscles at the same time, both agonist and antagonist. And basically, these are those conditions, the dystonia specifically, in which you see a child that tends to present with like a extension or a rotation of the limbs that can be quite painful, but it's potentially episodic, so it comes and goes. It's not as stable as the muscle tone abnormality. And then in a subcohort of children, we observe the onset of seizures or characteristic behavior that could be potentially misdiagnosed for autism, so autistic-like behaviors. And you see that this was observed in a number of children, and so you can get a little bit of a sense of what is the frequency. Again, this is on a cohort of about 217 subjects, but you see that only between 180 and 190 subjects had enough information to be able to go through these list of assessment, the list of symptoms, but still gives you a little bit of an idea of what was the first element that was observed. And then the other thing that we wanted to check was, over time, what should we be on the lookout for? What are potential complications that I might potentially expect and potentially plan for specific screening or follow-up? And so we observed that children can present respiratory issues or cardiac issues, specifically about 17% of the group that we observe had at least one episode of aspiration pneumonia. And this typically comes into play when a child has unsafe feeding. And so potentially they aspirate some food or some liquids. We observe some cardiovascular problems that included aortic dilatation or calcification, but also potentially heart defects like valvular heart defects, arrhythmias, or malformations altogether. And then some children required artificial ventilation for an extended period of time. I think that our cutoff for the study was 2 weeks of consecutive artificial ventilation. As expected, because of the frequency of unsafe feeding, about 38% of the children that we had enough medical information on went on to have a feeding tube placement, and that included both a nasogastric tube, a gastric tube, or a GJ tube, and 35% of 35 subjects out of these 62 had completely reliance on gastric feeds, and so they were not fed by mouth anymore. A number of children also presented with gastroesophageal reflux, and then, as expected, we also failure to thrive as not a symptom of onset, but occurring later in life, and also recurrent vomiting. We observe in some children incontinence or loss of urinary function, and this typically is more associated with the presence of a neurologic bladder. So potentially children are unable to have a perception of like the how full the bladder is, and it's difficult for them to be able to independently urinate. We observed some hematological problems that included both anemia and thrombocytopenia, and this is something that was not previously observed, or at least not with this frequency in this population. And then from a bone perspective or a muscle perspective, we observed specifically the presence of scoliosis in not an unsubstantial number of children, and also the presence of hip dislocation, and both of these conditions required surgery in a subgroup of subjects because either there was pain or it was unsafe because the scoliosis was progressing to a point that was making potentially complex for the child to breathe or to breathe well, or potentially we started to give a compression to the heart. And then from a neurologic perspective function, almost the entire population presented a global developmental delay, but this is a big umbrella that takes into consideration motor function, language function, cognitive function, and then we tried in subsequent studies to characterize a little bit better these profiles. Seizures, as I anticipated to you, it's actually quite a common occurrence, even if not like in everyone. About 30% of our cohort presented seizures throughout our follow-up period. And then we observed, as originally described by Dr. van der Napp, a loss of some abilities over time. So I highlighting the neurodegenerative trajectory of this condition, with loss of independent ambulation or assisted ambulation, of course, for the children that were able to acquire it. And then in a number of children, we observe spastic paraparesis, so isolated, so potentially children that don't present as much of a spasticity, but still that present impairment of low limb function. And yeah, basically these were the main signs and symptoms. But one other thing that we were able to do within this study was trying to understand if there are early predictors of disease severity. So because we know that not everybody presents in the same way, and actually you are seeing that there is a spectrum of manifestations, we were trying to see how early can we identify if a child is going to have a trajectory of condition that is going to be more towards a classic or more severe manifestation, or somebody that is going to have more of an attenuated manifestation. And after some analysis, what we observe is that potentially you have two parameters that were quite significant for prediction. What is the genotype, so what is the gene and the genetic variant specifically that is present in the child, and what was the time in which they were able to acquire specific developmental milestones. And in this case, we identified independent sitting. And so by doing an analysis on about 138 subjects, which were the subjects for which we had reliable information on genotype and developmental milestones, we saw that we can go as early as 9 months to have a potential prediction of severity. And so there are potentially 3 cohorts that we identified in this study. Children that have an early infantile manifestation. So these are typically children that present with a non-D249N mutation, so not the common variant, one of the other ones, and children that by the age of 9 months do not sit independently. And 9 months was chosen because that's a little bit later than the latest you would consider typical acquisition of independent sitting. And then the other group of children tend to differentiate based if they have a D249N variant or a non-D249N variant, but they sit independently by 9 months. We saw that these two groups, at least at the beginning, tend to look similar. And so you see that considering these 3 groups and considering as an outcome independent ambulation by the age of 3 years, what we see is that about 75% of the subjects that present with the common D249 variant will be able to walk by the age of 3 years, while only 29% of the subjects that don't present these specific variant present ambulation at 3 years of age. And by ambulation here, I mean independent ambulation, so without the use of any kind of device. And then within this group of children that are unable to, that are present the the non-D249N variants, we see that if you sit by 9 months, you will be likely to walk. About 69% of the group was able to achieve independent ambulation by the age of 3 years. Well, if you don't sit by 9 months of age, then the likelihood to achieve ambulation is 14%. And so you see, these are not perfect predictions, but this is as early as possible as we were able to identify these 3 different groups that we identified as early infantile and late infantile. And for the late infantile, we have these 2 groups based on genetic variants. And what are the trajectories within the population? And let me explain you these charts, these bar charts. So basically, when we consider the entire population and the outcome is independent ambulation, you see that about like 25-30% of the cohort is able to independently ambulate, potentially a little bit more than that. But there is also a subgroup of subjects that is able to achieve ambulation, but then start to lose it. And what you see is that potentially, what we observe is that within the D249N population, there is a higher chance of achieve ambulation, but there is also a potentially higher chance to lose ambulation over time. While in the late infantile form, so the children that are sitting at 9 months but don't have the common variant, they still have the ability to ambulate, potentially with a less likelihood. It's probably more like it was like 60%. But they tend to lose less likely ambulation compared to the other group. And then in the children that present the early infantile form, independent ambulation is extremely rare to achieve. And I want to specify that the more you move on the right in the graphs, the more we're making assumptions, because you see that our overall population is decreasing, because now we are better at diagnosing children early on, but potentially the genetic testing has been available like more broadly quite recently, and so we have less adult subjects that we know about, but potentially that might be because of underdiagnosis. One other thing that we wanted to see was, okay, let's see if besides independent ambulation, there are specific differences between groups when it comes to medical events. And so what we were seeing is that early on, children with the D249 variant tend to achieve milestone quicker. So you see that the first graph where there is the letter A, the blue line means basically that you are a D249N group, and then the green, you have a late infantile, and red, you have an early infantile. And so you see that when you present developmental delay, it can be based on your specific disease subtype. And so you see that children with D249N tend to present a delay later on in life compared to the other subgroups. What we saw also is that children with an earlier manifestation of the disease tend to present earlier and more frequent seizures, the need of needing feeding tube placement and gastric feeds. They tend to present a higher frequency of scoliosis and potentially also of hip dislocation. And all of these is not only more frequent, but also at an earlier age, while the other 2 groups tend to present quite similarly, maybe with the exception of developmental delay between late infantile and D249N. The other thing that we checked was trying to understand what is the disease trajectory within the population when it comes to gross motor abilities and communication. And so what we did was basically taking the medical notes that we were able to collect from children that are participating to the study here at CHOP and worldwide with all of our collaborators. And we went to these medical notes and tried to score as much as possible motor and communication function from these notes. And so we were able to identify some preliminary trajectories of function, which I want to be also very, very clear in specifying that in the later stages of life, because of the smaller number of subjects that we have enrolled in our studies, these like results tend to be a little bit less certain. And so you see that these gray bars that are the error bars tend to open up quite a bit. But basically what we see is that children with the D249N variant and the late infantile tend to present a better motor function. And just to direct you on how this graph works. So a score that is as close as possible to 0 for the gross motor abilities or to 1 for the communication abilities is a higher function, and a score as close to the highest score, so 6 for motor and 5 on communication, is considered a worse function. So the majority of children with D249N and late infantile forms tend to present with a milder, with higher level of acquisition of motor abilities, but then they tend to lose them over time, and potentially subjects with D249 variants tend to present a quicker loss of abilities, while those are maintained a little bit more in the late infantile group, while in the early infantile, we observe that there is a lower likelihood of achieve motor abilities up to sitting, and then there is also in that situation a loss. And we observe something similar, but a little bit less striking also for communication abilities. And typically this is because what we observe is that there is a reduction on the quality and the quantity of production of verbal language. And so potentially children require augmentative communication devices that might make it more challenging for them to be effective communicators within the family, but specifically outside of the family. Again, this is the same as I was telling before, at later stages of life. What we observe is that we have a smaller number of subjects, and so we're making assumptions based on a small group of a small population. And so what is going to be important in the future, we'll need to see if by expanding our study to enroll more subjects and potentially more teenager and adult subjects, these preliminary results will be still valid. And so what we were able to conclude in this paper is that TUBB4A is a spectrum, and TUBB4A cannot be considered a single condition as originally described before, so HABC, but is a spectrum, which includes HABC, but is not limited to it. And so you see on the table, well, first of all, the figure above basically shows you who are the different subjects that were enrolled in this natural history study. And so you see that we have a gigantic number of genetic variants, and some of them tend to be more common than other ones, but there is also not an unsubstantial number of variants that have only been described once in the literature or that were present once in our database. And then we started to see that for some of the variants that we were able to identify, there is the potential of predicting, not with a 0% error rate, but with a reasonable rate, if a child that presents with a specific variant will be able to sit by 9 months or not sitting by 9 months, and so falling more into the early or late onset, late infantile form. And so basically you see that about 72% of the children with D249N tend to present in the late infantile form. About 80% of the subjects with the ARG391 HIS variant will have late infantile form. But for example, none of the children with ARG262 HIS present with a late infantile form. And again, these are small numbers, so we're still working on that. But you see that once you start to have enough power and you're able to enroll enough subjects in these studies, what you can see is that you start to be able to direct a little bit more families into what to expect and potentially what to be on the lookout for potential follow-up and, clinical management of children. That was the natural history study. So this is a study that we conducted retrospectively. At the same time, our focus was also on trying to understand exactly what is the impact that this condition has on caregivers and affected children. And why is that important? Because in order to design therapeutic intervention and a structure for therapeutic intervention that is able to capture what is meaningful for families and for children and potentially reflect that in the context of a clinical trial, we need to ask families much more than was done in the past, what is relevant to you and what will be considered an important outcome for improvement of overall quality of life of children. And we conducted this through the administration of surveys online and interviews, which I'll present a little bit later. And these surveys were trying to focus on what is the area that is the most impacted in your child's life, and what is the not only the area, but also the magnitude of impairment that the child presents. And so we applied existing tools. They are online questionnaires that explore quality of life in a pediatric population for the PQL, and specifically in a population with disability in the CP child. And these were lengthy assessments. So we are extremely, and I personally am extremely grateful for everybody that contributed to complete them. And basically what we observe is that there is a priority that families were able to identify that was mostly on general comfort, general health, and ability to reduce as much as possible the impact of that this condition has on the day-to-day life management, which is I want my child to be happy. I want my child to be able to save eating. I want my child to be able to have overall an improved quality of life. But at the same time, also, we were able to identify other targets. I want my child to be able to communicate better and to understand better with other people. I want my child to be able to have a better motor function. Specifically, it seems for indoor moving, so potentially achieving an element of independency. And we also saw that there was a little bit of a difference on priorities of families based on the age of the child, and so potentially on how long the disease has been present, but for the vast majority, they were overlapping. And what we observe is that the areas that are the most impacted are the motor aspects and the independency aspects. But surprisingly, or potentially not very surprisingly, the aspect that is still more relevant, even in light of that, was overall happiness, overall health, and communication. And then we explored also the impact of this condition on the caregivers, because this is a condition that tend to involve not only the child, but the entire network around the child. And so what we observed is that there was a significant impact on the families, and not only in the family, but also on overall social network, including siblings, grandparents if present. And it was both a physical and a psychological impact. And this is for us very important to capture in this way, because it's a very important tool to be able to bring up that a potential improvement in the condition of a child does not only have an impact on the child, but potentially on the entire network. And so this was done through surveys. But then another thing that we did was trying to explore what are the abilities of children. So children tend to be very complex in the evaluation, and I'm talking about general children, because children tend to have a variable level of compliance. Potentially, they are tiring out a little bit more quicker than you would expect from an adult, and they tend to, but on the other side, they tend to have, at least for some of the earlier milestones, slightly predictable acquisition of abilities. And so the majority of assessments that capture functional abilities are standardized for either a specific healthy pediatric population or on a specific subgroup of children that have a condition, but typically that condition is stable, so it doesn't change over time. And so because of that, we don't always have the best tools to evaluate children. And once we identify potential tools, we need to demonstrate that they are appropriate within the specific population that you want to evaluate. Because if not, if you don't have the right tool, you will not be able to describe the population, and potentially it's going to be more difficult to identify if any kind of intervention has an efficacy or not compared to the baseline of the subjects. And so what we did was exploring one area independently from the other one. And so we started with gross motor function, and we were able to enroll 45 subjects on gross motor function assessments. We applied the gross motor function 88, which is an assessment that is typically conducted by physical therapists. And this study originally had in-person assessments, but now we're able to administer those assessments also remotely through Teams, for example. And so we're able to involve many more families into this specific research project. And what we were able to identify is that the GMFM88 suffers a little bit of what is called the floor effect. So what it means is that within the population that was applied, the gross motor function tends to differentiate not very well in children that have a severe manifestation of the condition, but potentially tends to do quite a good job in children that still present residual motor function. So for example, they're able to sit independently, they're able to roll or to crawl, to have basically some sort of floor mobility up to independent ambulation and more complex coordination like jumping, running, balancing on one foot, etc., etc. We needed to do this specific study because the gross motor function 88 was designed for not children with a leukodystrophy, but on children that present cerebral palsy, which is a condition that is static over time. And so the GMFM88 was supposed to measure changes over time of a rehabilitation treatment in children with cerebral palsy, but these children were not specifically declining over time. While the GMFM88, in this specific subpopulation, we will also want to see if it's able to capture change over time in that sense. The other thing that we did was exploring adaptive behavior abilities. What is adaptive behavior? It's basically how a child is able to modify and to complete and achieve the completion of specific tasks in a day-to-day life without such a specific focus on the quality of completion, or specific, more than quality, the strategy of completion. So one example that I like to use for the specific assessment that was done was the communication domain. There is a section of it that explores expressive language, so the ability of a child to communicate effectively. And that communication for this assessment does not require reliance on verbal abilities only, can also focus on nonverbal abilities, such as signs or such as augmentative communication devices utilization. And so what we observed was that social abilities and to some extent communication abilities tend to be much more preserved than motor abilities and overall independencies, and that when we go specifically in analyzing the subgroup of communication function, receptive language, so the ability to understand, tends to be more preserved than expressive language, so the ability to express themselves, which is on its own more preserved than the ability of communicating to writing or the ability to read. And so what is also important to note is that not an unsubstantial amount of children present abilities that are not that dissimilar, at least in one of those domains, to what you would expect by a typically developing child, specifically when it comes to receptive language. Of course, there is some variability, and because of the relatively small number of subjects that we have enrolled so far in this prospective study, we've not been able to do differentiation based on genetic variants, for example. One thing that we observe also is that independencies are quite impacted, specifically personal independencies, because there is an impact of ability to eat or ability to complete personal hygiene, and that while overall motor abilities are impacted, gross motor abilities, so the ability to move around, tend to be more impacted than fine motor abilities. So there is some ability of the children to manipulate objects, potentially with a lower quality, but still with some level of efficacy. And so this is what we were able to observe in the context of these interviews that were conducted with families, both in person and remote. Because another advantage of the Vinland Adaptive Behavior Scale 3 is that it can be easily administered remotely. So this was the standard that we try to generate, to basically generate baselines in this group. Why is that? Because first of all, we want to be able to diagnose as early as possible a child, and we want to be able to predict as much as possible how this child is going to do over time, but also having metrics and assessment that are able to delineate very well these trajectories over time, because we are in an era in which therapeutic approaches are starting to become available. And these therapeutic approaches are both in the sense of symptom management, so management of the conditions that I described before, but at the same time also potentially disease-modifying interventions, they're called. So interventions that can modify entirely the trajectory of the disease by either preventing it or by mitigating a lot the manifestations. And one of the most promising therapeutic interventions are the antisense oligonucleotide treatment. I will not go into the specific details of the therapeutic intervention that are currently using these treatments, because that is going to be something that Anne Lorem or Synaptics Bio will be able to comment much more. But I wanted to give you an idea of what are they. So basically, as I mentioned before, TUBB4A causes, the variants cause toxic gain of function, which means there is too much protein that doesn't assemble very well. And so basically that makes the cell not work as well as they should. And how our proteins are made is that when you have the DNA, which is basically the place where all the information to generate the protein are stored, this DNA is used to basically make a copy of RNA, and RNA is basically a single strand of nucleic acid that basically allows for the translation, so the generation of the protein to some extent. And basically these antisense oligonucleotides are very short pieces of nucleic acid, like 15, 20 bases, and they're able they can be basically built to attach specifically to those sites of the RNA to basically block the hyperproduction of this protein. And so potentially in this way, you can block one of the sources of the pathogenesis of the disease, and in this way try to restore, or in some extent at least modify, the expression of the specific protein. And these are very, very complex to generate treatments, but you see that potentially they can be quite targeted, but at the same time also fairly versatile. So they potentially are not limited to one specific variant only. And I have to thank our collaborators here in the Dr. Van der Verse research group that are scientists that are currently studying the effect of this treatment on animal models. So basically, the bench science group here at CHOP was able to generate an animal model that replicates a condition observed in HABC specifically. And these mice were observed in their natural behavior as symptomatic mice with the TUBB4A variant, but also what was the effect of the treatment of the ASOs on this animal model. And so what we were able to see is that if you see on the center of the slide, the survival of the animal population was significantly incremented. So mice that were having the TUBB4A variant and that were not treated are colored in blue, and the ones that are treated are colored in purple. And so you see that there is a significant increment of survival from about 100 days to more than a year, basically. And that when it comes to behavior, so the functional abilities of these mice, you can see that there is an increase of preservation of function. It's still a little bit impacted compared to the gray and the black dots, which are healthy mice that in one extent were not treated with anything, and in the other extent were treated with antisense oligonucleotide. So you see there is still a difference between performance of a healthy mouse versus a mouse that has the TUBB4A variant. But at the same time, there is a much bigger there is a preservation of functional abilities for a much longer period of time. And specifically on the right, you see that when you observe what you see in healthy mouse, so the top two panels, you see that there is that kind of like thick substrate of myelin that basically encapsulate the axons, while in the third panel, so bottom left, you see that this coating is extremely thin, but in treated mice, this thickness was bigger. And so you see that potentially this is a treatment that can preserve and potentially facilitate the generation of a myelin. And so potentially increasing in the, directly the functional abilities of these treated animals. And then together with a group of international experts, we were able to start to draft some considerations and potential recommendations. And all the data that I've presented so far, it's unpublished, but specifically the study on the natural history and the study on the impact of disease are in the coming of being published, and the paper that delineates motor aspects of the within the TUBB4A leukodystrophy population is already published. So basically what you see is that we suggest to evaluate orthopedic health, potentially considering management of bone health and keeping as long as possible weight bearing to avoid potential fracture, hip dislocation, evaluating also potential endocrinological follow-up, and evaluate repeatedly hip and spine to basically determine if there is the occurrence of hip dislocation, hip subluxation, and scoliosis. And then it's very important to have a strong relationship with a group of rehabilitation experts that can include PMR, doctors, physical therapists, and occupational therapists. It's very important to take into consideration that there can be movement disorders such as spasticity, tremor, dystonia, or rigidity, and that there are medications that can mitigate these symptoms. And these treatments can be either oral, can be used in the context of like a pump, or can be more invasive, like for example, Botox injections. And this should be done in the context of like a very, very specific, like a specialist group. And it's important also to pay attention to seizures that might be present in the context of TUBB4A, because some of them might mimic some movement disorders, specifically if a child is more affected, and so it's more difficult to understand a change in behavior when a child is seizing versus a child that doesn't have seizures. And then it's important to do studies for determining what is the quality of swallowing, so swallowing assessment that should be repeated regularly, and then modulate the diet based on what is observed by that, because it might be possible to be in a situation in which like specific foods or specific consistencies become choking hazards. It should be considered the evaluation of a pneumology, specifically if a child starts to develop respiratory difficulties because of the potential aspiration pneumonia that might be observed. And in general, the challenges in some children with management of secretions, which on their own can also cause epigestis pneumonia. And then it's very important to monitor weight and time requested for meals, because one of the things that can be very detrimental for a child or for a teenager with this condition is loss of weight, with which can make them more fragile subjects, and potentially taking in consideration gastrostomy tube if children are unable to consume enough calories by mouth. One other aspect that is very important to management is constipation and presence of repeated infections that can be due to neurologic bladder, or in general to potential alterations in the motility of the intestine. And then managing, very important, manage and check if the child is snoring, is not sleeping well, has frequent awakenings, or is not very well rested, because this child might be developing apneas, and so a sleep study might be useful. And because we observed we had findings in our study that were quite surprising. So basically the presence of cardiac abnormalities in a frequency that is higher than the general population. There is also the recommendation of doing a baseline evaluation through the use of an echocardiogram. And then it's very important to do a psychosocial assessment to basically have an understanding of what are the diagnoses, what is the diagnosis and what are the implications of the diagnosis, but also access to medical resources and to support programs in general, because we saw how TUBB4A related leukodystrophies have a spectrum of manifestations that can be quite complex and very difficult to manage for a single family group, and sometimes even by a single care group local to home. And one other thing that I would like to share is that if there is anybody that is in this call that will be interested in participating to the research projects that we are conducting here at CHOP, but more extensively internationally with a list of collaborators that I will show you in a second. We have a link where you can basically refer to us, and potentially this is the way for us to get in contact with you. And then if you want, you can participate to the natural history study, the retrospective piece, the prospective piece, both of them. But basically you see that by increasing the number of people that we're working with and that are able to support our research, we're starting to be able to identify some potentially very important aspects to monitor in the context of incoming therapeutic intervention. And with that, I would like to thank very much everybody that has participated to these extensive studies that we have conducted, because they are substantially time consuming and require a lot of effort from families and for children, because this assessment takes time to complete. They can tire out children. They can be part of a research encounter that is occurring in the context, for example, of a clinical visit. So it elongates not insubstantially the amount of time that a family is spending with us, or families that are participating remotely that are, willing to invest time in their day to be able to help us trying to understand more. And so I'm extremely thankful, and we, by extension, are extremely thankful for everybody that has participated so far. And after that, I would like also to thank all of our international collaborators that have been fundamental to be able to complete these studies, as you see, because TUBB4A related leukodystrophies is such a rare condition. It's important to unite all the strengths and try to come together to basically understand more, and with understanding comes also the ability of treat better. And so I've included all of our collaborators from the Leukodystrophy Center here at CHOP, Leukodystrophy Center of Amsterdam, Milano, London, Dallas, Beijing, Melbourne, Brasilia, Rome, Montreal, Sofia, Salt Lake City, Yokohama, Dallas, Harwell, Birmingham, and Barcelona. So thank you very much, everyone. And yes, that was my last slide. So I will stop sharing my screen.
Dr. Gavazzi, thank you so much for sharing all of that data. A lot of that is very new to the families, and it's such an incredible insight into what we can glean from the natural history study. So I'm going to open it up for questions here in a second, but to my TUBB4A population, I'm going to preach at you guys for a second. Please, please, please participate in this natural history study. I've been, talking to Peter Hong, who has been organizing a lot of the assessments right now. Out of the 118 families, this is end of September, out of the 118 TUBB4A families, only 17 of us are up to date on our assessments as of the end of September. I'm sure that the number's gone up since then, but as of the end of September, 17 of us and our kids are up to date on those assessments. This is critical. It's so critical to participate in this, not only for us to have these data points and be able to have families come in and kind of know what to expect for their kids based on their variant and protein change, but this is going to be critical because natural history studies, this is what we are aiming to use in lieu of placebo for these clinical trials. The more data we have, the better armed we are to go in and not have your child go in and potentially receive a placebo. For you to potentially go in, have your kid put under anesthesia, and have saline injected into their backs. We have to come together. We have to take the time for our kids, for the kids that are to come, to support CHOP in this effort. It's not just used for CHOP. It's funded by the NIH. It's going to be open for use. It's going to be open source, open data for the empowerment of our community, for the good of our kids. Please, please, please take the time to participate. Use the link in Dr. Kavazi's presentation. We will be linking his presentation on our Kenslo TUBB4A website along with the recording of this session. It's going to make such a difference, whether it's the AAV research, whether it's the ASO research. It's going to make such a difference for our kids to participate just in understanding the disease and also any future treatments. So with that, I am going to open this up for questions. We do have representation from Synaptics Bio here on the call. Dr. Maya, would you be willing to just introduce yourself? And we are going to be, he is going to be able to answer questions that he is able to answer. They're still defining strategy, timeline, and goals, but having representation here from Synaptics is huge. We're so appreciative to have both representation from CHOP and Synaptics Bio on this call. And with that, Dr. Maya, would you say just a brief hello to the group?
Yeah, well, thank you very much, first of all, for inviting me to that really fascinating webinar. So I'm very happy to join you. I mean, in my past experience, I've been chief medical officer of another company before, working on a rare disease. For us, it has been essential to work with families and with patient advocates to progress our plans for clinical studies and later on to conduct them. So apart from us really staying grounded and learn about you, about your courage, about your resilience in managing a very difficult situation, your advice has been essential and will be essential for future study planning. So that is extremely helpful, and I hope that I can continue the dialogue and then see you in person in Chicago in June of next year. And second, I just wanted to congratulate Francesco on an amazing talk. I think you entertained us for an hour with detailed knowledge on your data, with absolutely essential findings that we will use for our study planning. So that was valuable in itself. Just a few words about Synaptics Bio. So I say good evening here from Europe. Company is based in the UK. It is a virtual company, and I myself, I'm based in Switzerland. So it's 6:30 in the evening for me. I can just give you some general overview. We are active, as you may know from our website, in developing an ASO for the treatment of TUBB4A. As a public as a company, we have to abide by the guidelines of regulators. What we have to do to come up with a clinical candidate. As you have heard from Francesco, first step is extremely delicate and difficult. That is to make a molecule that fits as an ASO, then essentially show in vitro, that means in a test tube, that it is able to suppress the formation of this pathological protein, so to remove that toxic gain of function. Then quite a couple of safety evaluations. First, we have to show that it doesn't do any harm to any other tissues. It doesn't bind to anything that is otherwise essential for a healthy organism. We have to synthesize the material. We have to formulate it into a drug product that can be administered to patients. And we are currently in the process. We are moving ahead very quickly and I must say very successfully. We have narrowed down the list of candidates to very few. And early next year, I think we have the luxury of being able to select between appropriate candidates that we will move further. That will then go into formal clinical enabling studies. So if all goes well, we anticipate that we'll be ready in about a year from now to initiate studies. Now, being a UK-funded company, not entirely, but partly by UK grants, it is evident that we are in touch with sites in the United Kingdom, but we have been collaborating with TUBB4A since our inception. So the other perspective will be the United States for us. So the plans are maturing. We are planning regular interactions with regulatory authorities to guide us through that process, to come up with a smooth and seamless process for developing that drug. So all I can say is we are on the way to do it, and we continue full steam.
Thank you so much. That's amazing. We really appreciate that update and appreciate your presence here today. With that, I'm going to open it up to questions from the group or any clarifications that are needed. Kristen, I see you have your hand raised. So.
Yes. No, I have a daughter, Olivia, who's 20. So we've been living with this for a long time. And a lot of everything that was presented today is exactly what has happened. So I just want you families to know that take note of everything that you just saw today, because I can validate for Olivia every single thing that was presented. So, but on my question is, I have two older daughters, and one of them is newly pregnant. I know we did a test because we were part of an NIH program, of the Undiagnosed Disease Program, back in 2011. And I believe there was some blood work that we did to see if they were carriers. I'm just wondering if there's anything else that could be done, that should be done, to test for this again. Like, has there been something different, or am I like on the wrong path entirely of how you like would find this in a new mom? And if that's out of your wheelhouse, it's okay.
No. I can comment partially on it. So basically, as I was mentioning before, it's typically TUBB4 is a de novo condition. So it means that it's rare. It's still possible. It's quite rare that it's inherited from either one of the parents, just because it's autosomal dominant. So one copy, it's enough to present the disease. And again, because this is a new condition, or at least a recent one, we cannot say for sure that there are not people that have a TUBB4A variant that don't have the disease itself. But gotcha. What we see is that typically there is a manifestation of the condition, and so it's unlikely that it's not de novo, so it's inherited. We cannot exclude it. The other thing is that typically extensive genetic testing, if it's not like a panel that specifically target only some genes, but it's more extensive in the way that you do the analysis. Typically, TUBB4 is picked, like if you do an exome sequencing, for example, it should be picked. Of course, if there is a panel of genes only that is done, like it's a protocol, potentially if that gene is not studied, potentially you can miss that. But it depends on the specific laboratory that is doing that. I'm not a geneticist, so no, I will leave other people on the call if they are more knowledgeable than I am. But what I would say is that from what we know, the majority of people that are affected are de novo. And so it's not something that was seen in the parents, it's something that was in the child only. But that's the situation. And then depending on the laboratory, the gene can be studied or not. That depends a little bit on that.
Okay, thank you so much. We were told that back years ago. I just thought with all the advancements that have come, maybe there's something new that we aren't aware of. Just being a mom of another kid, even though she doesn't have TUBB4A, our family has it, in a way. So Thank you so much. I appreciate your time. And you did a wonderful job with your presentation. And thank you again for joining us.
And I did ask in the chat the normal lifespan of a mouse there. So thank you for responding within the chat, Dr. Gavazzi. So the normal lifespan of a mouse is about, you said 24 months in there. And right now you said with the ASO, what you're seeing is about 400 days for the ASO treated mice.
Yeah, a little bit less median. I think it's closer to 1 year, but compared to the traditional animal model that has a median lifespan, so 50%, median means 50% of them survive beyond that and 50% survive less than that. So it goes from about 100 to about 370, 380. I don't remember the exact number for that. Well, I would say, yeah, the lifespan of a lab mouse can be 2 years. Sometimes they can push to 26, 28 months. Varies a little bit also in that sense, but that's more or less the ballpark.
And within that mouse model, like I know that you guys have requested like blood from my child a couple of times, right? So within that mouse model, are you utilizing different variants like in protein changes within that mouse model, or is it only isolating the common variant, which the 249 variant, which is HABC? Have you started the process of studying the other variants and impacts?
So the current one is still the D249N because it's the one that is well, first of all, the most common, but also, and again, on here, I will be very clear in disclosing that I'm not a basic scientist.
Yeah.
So, on that, but my understanding is that there might be plans in the future for that. There was also some interest in potentially using other models besides the animal model, but at this point, I know that the current animal model that is getting used for this experimentation is the mouse with D249N. Potentially in the future, yes, but I'm not sure yet about the timelines of that.
Okay, great. Thank you.
Thank you.
All right, we have another question.
Is that me?
That's you.
Yes.
Yes, it's you.
Okay, hi, I'm Karin, mother of Serinde. We live in close to Amsterdam in the Netherlands, so a patient of Professor van der Knaap and Dr. Wolf, who you mentioned Professor van der Knaap, of course. Our daughter is 24 and a half, as she would add already. And so what I'm interested in the future, will any of the treatments, will it do any good for children where all the progression has already happened? Or is the idea really that the treatments will only focus on young children where not so many symptoms have? I understand that you want to start with children where you can really see the effect, but would it be future music, as we would say in Dutch, that it would also work for, like Kristen just mentioned, her daughter's 20, a lot has happened to our daughter. She's lost a lot of skills, etc. Could either Uwe or you, Francesco, say anything about that? About the ages when, or the stages of the progression of the disease, when would treatment still be an option?
I can maybe start. We are in the process of talking to investigators and regulators also on the design of the clinical studies. So we have proposals ready, and with inclusion-exclusion criteria, our approach will very likely be a stepwise. So start with a narrowly defined population where we have the best chance of showing an effect. But given safety and hopefully some preliminary efficacy, we have the plan of stepwise widening the inclusion criteria to another population. So the plan is not to per se exclude someone on saying there's a poor chance of success, but as I said, it will go step by step. So also those who may have a poorer prognosis will be able to receive treatment.
And another thing that I can comment on the fact is that, as we were discussing before, natural history data are necessary to be able to design better trials and identify potential. The technical term is endpoints. So basically what you measure to see if there is an efficacy or not. And we have a smaller adult population just because the diagnosis was not done when people were children. And so potentially there are a lot of adults that are undiagnosed. And so we will need to increase as much as possible and focus as much as possible on a increase of the number of subjects that participate to the study to also have an understanding of what is the adult trajectory. Because what you were seeing in all of our figures is that the error bar increases dramatically after the age of 15 just because the number of subjects is smaller. And so potentially that can come with assumption biases basically, or selection biases. But yeah, that's like it will depend on the clinical trial design, and the clinical trial design is also based not only on the specific therapeutic intervention, but also on the knowledge that there is on the general trajectory of the condition in the population.
Yeah, I have some additional thoughts on that, if I could, please, because I think there's a lot of children here that are older that have undergone significant surgeries, including spinal fusion. And with respect to the ASO and ongoing injections and side effects and risk factors, I think the population of particularly the older children, the parents with the older children might want to understand the implications of that and how that's sustainable for the life of the child, because it's ongoing quarterly injections with, obviously limitations relative to scoliosis and spinal fusion.
Thank you.
Dr. Maya, I know that, with your Synaptics being based in the UK, you are considering a trial that spans outside of the UK. Are you looking at like the GLIA network of hospitals to potentially roll out, or is that something you can speak to?
We haven't made concrete plans now for particular sites, but I don't think we can accommodate the whole clinical development just in the UK. So we will definitely go where the sites of expertise are, and they are also in the US, but they're also in particular European countries. Notwithstanding, if a suitable patient lives somewhere, there will be travel assistance provided, so you are not tied to a hospital just that is next to you.
Okay, thank you. Does anyone else have questions for Dr. Grazzi or Dr. Maya?
Yes, hello, this is Paco from Spain. Okay, I would like, sorry that I insist, okay, because I am the father of a 3 years old boy, a very happy boy, but with this leukodystrophy. So I don't know, it's really need to know to try to fight more now in the future, to know if really is there a plan already defined. I don't know. I know that is that you need the necessary information out of the natural study and everything, but I don't know if you have defined or a number of cases that you need to try to provide this antisense solution, or it's a matter of time. I don't know. Okay, it's something only I know that it's very difficult, quite difficult, but I would like to know, to try to share with our colleagues, our families, to say, hey, here we could have something close, maybe it's 1 year, 2 years, whatever, but I don't know if you have already defined or not, and I'm sorry if I insist on that.
You're probably asking me. I mean, if you mean in terms of particularly patients lined up for his trial, no, don't have such plans. But as I said, the plan is to initiate clinical development in the UK, but then expand as we gain confidence and more data. And there's essentially no restriction to any particular country, but it depends more on what population we start first and what population we start somewhat later. So I can't be more precise, I'm afraid, at this point in time.
Okay, and according to that comment, we are going to have, I think that with that antisense solution, antisense this trial, is any problem in any country because it's going to be based there in UK. I don't know if, for example, the patients from Spain, we should move there, or is it going to be possible to try to move this trial to Spain or not? I don't know. It's only for you to understand. Maybe it's out of this meeting, but for understanding better.
I mean, there is not much different in the requirements for a clinical study between UK that has left European Union and Spain being a European Union country. I cannot comment specifically on when or whether we may go to Spain, but on the other hand, as I said, there can be arrangements of patients joining a study in another country if that fits to the study protocol.
Okay.
So, Dr. Maya, am I correct to say that the initial rollout, like what the intention is with the initial rollout of the ASO, or the goal is to target the HABC 249 variant in the initial launch of your clinical trial?
I mean, the target will be HABC, but I don't think that science is mature to say we restrict it to one particular mutation. So it depends more on the symptomatology and the onset. We will have require a mutation that is associated with TUBB4A and HABC, but as I said, no restrictions on a particular one.
Okay, so the ASO is non-allele specific. You expect the ASO to be non-allele specific then?
Yeah, that's correct. Yeah.
Okay, great. Thank you so much.
Thank you.
Anyone else have questions?
I do. Can you hear me?
Sure can.
Okay, perfect. Just questioning if there is any more research based on different type of treatments. Then, my son, he's 13 years old, and he was just diagnosed about 3 years ago. He is a lot more functional just based on what the doctors have mentioned for him. We live in Minnesota, and I know there is a lot of new investigations about maybe ASO treatment. However, any other treatments besides that one that they have been looking into it? The one I have found yesterday, actually, I joined a group for, there is pretty much stem cell patches. They work with phototherapy patches, they call it. And they have been pretty much a lot of people with CP specific. That's what the biggest reason that I joined them. And I asked about how will be the improvement based on what will be the helpful piece of this medication itself, because it's just a patch that will be placed on specific points. Could be specifically for my son, it will be in behind his head. This is really new information for me, just so you know. Just kind of be patient with me a little bit. But the company is called Live Wave, and there is something that it will be placed on his whatever, and he placed on the back of his head, or it may be on his legs. In his case, his tone on his legs pretty high. He has low tone throughout his trunk. Then have you guys done or have you guys heard about any other type of treatments specifically with stem cells? My son actually, when he was 2 years old, before we even found that he had TUBB4A, he was diagnosed with a chromosome 16p 13.11 microdeletion is called. In his case, he was actually implanted some stem cells from an animal. We did not really see any impact on it, but I was just wondering either you guys know about any other besides just only ASO, because my biggest concern is he's getting older, and I mean, as all as parents, we kind of want to know, like, it's going to be really hard to get into these type of treatments, but some other treatments that you guys have heard about it, I'm not sure if you guys have heard about these ones specifically, then just kind of like, I was just wondering if you guys heard anything about it. We haven't tried it. I will order them, and probably I will try it on myself first, just how I did it for stem cells. I requested to be injected first on my son, and then I just only not major things on me and not major things on him, but I was wondering if you guys know anything about new research about that, like different things besides ASL.
I'm not aware of that at all. It's the first time I hear that. Francesco, do you know more about that?
Never heard of it before as well. What I know is that there have been no studies on animal models or cellular models on TUBB4A related leukodystrophy that use that specific therapeutic intervention. So, but I have no familiarity with the specific company or the specific technology used for that, this kind of approach.
I do know that the PMD Foundation has been doing similar research for that specific approach. And I have spoken to them, to the investigator that has actually been working with Dr. Vandiver, I think, or is not necessarily working with Dr. Vandiver on PMD, but it's certainly something that it is in research right now. I don't know how effective it is, but it's certainly worth looking into. It's on our list of stuff for us to, on the Foundation to Fight HABC, to look into that further.
Perfect, thank you. Perfect, thank you.
Thank you, everybody. We have time for a couple more questions, and then we'll move into updates.
I did want to ask.
Yes.
Oh, go ahead.
Yes, just one question from Spain. I'm French. I'm father of Carolina. My name is Stefan. And I'm not so familiar about understanding when you say in UK you will start more HABC. You mean some specific variant within the TUBB4A, which type of criteria? Taking criteria of having several type of children with the type of mutation or with the age, like Karin was asking before. What is the overall criteria to start with, to define maybe in the future a plan that we all want to hear in a couple of months and not years? Thank you.
We have a protocol that is maturing, so the initial goal will be to patients who are very similar to what Francesco described as a so-called late infantile population, but as we said, without a restriction to a specific mutation, who are at least remotely ambulatory, and then expand stepwise into those who are no longer ambulatory, and then expand into those what are labeled as early infantile. So that's the current plan. So I cannot comment on the speed of the steps. It really depends on funding and stepping and safety and initial efficacy that we may see. So I'm afraid I can't be any more specific right now, because it's also, as it's maturing, we have to go to regulators with a ready protocol next year to get their opinion on that, and that will finally yield a final protocol with selection criteria.
Thank you, because at least it's something incredible compared to when we diagnostic Carolina, like 5 years ago when she was 6 years old. And at that time, we were just connecting between father without any initial plan. So it's really promising. Of course, we are impatient, but we have also a lot of hopes thanks to this recent movement. Thank you.
Hi. Can I ask something too, please?
Yes, go ahead.
Hello, hiya. Yeah, my daughter's 24 as well, and she had her diagnosis. She was late in development, so I suppose hers is like the infantile type. But she did gain ambulation and then lost it, and like we've been discussing. So she's got a variant that no one else has got that we know of. She's just individual. So once again, I guess it wouldn't make any difference as to how likely she'd be a suitable candidate, assuming. Is that correct?
I'll repeat myself. So
Yeah.
there will be no restrictions to the
Yeah.
specific genotype. So
Okay. Yeah.
because we don't know what genotype predicts what genotype. I mean, there are some interesting findings that Francesco presented, but we don't do that right now.
No. Okay. Thank you. And the other thing is, I wanted to just ask something about heart defects. Because I didn't actually realise that it was something that was quite common in our children. I mean, my daughter's never, well, she did have a heart murmur when she was quite young, about 4, but she had an echo done, and they said it was an innocent murmur, and they called it a venous hum or something like that. So I don't know, from that, would I be able to assume that she is okay in her heart health? I don't know. We don't really have any contact with hospital now that she's 24. Adult services in the UK don't seem to really keep on top of. We have to keep referring ourselves back to the physio and the OT and things like that, because we don't have anybody on board sort of directly. Our first port of call is to speak to a GP, and that's also quite difficult in the UK, we find. So I don't know. Should I be doing anything about this, or can I assume that she had an echo done when she was 4, and there was no problems found as such?
Yeah, so I don't think I can comment on the specific case, but what we suggest in the guidelines that we're going to share, basically these guidelines that I presented are going to be shared as a document together with the publication, and that can be available and shared with practitioners that maybe are not as familiar with this condition.
Yes.
But we suggest an echocardiogram.
Yeah.
That should be able to capture at least the variants, the anatomic variants that we were able to identify within the 200 children that we have evaluated. Of course, there might be something else that we're missing because of like the relatively small number, but this is what we comfortably were recommending.
Right. So it's a relatively small number, but it's still something that should be checked.
Yeah, I think for us, it was 9 subjects out of like 120 that had the cardiologic evaluation. So like 1 in 13, 1 in 14.
Okay. Thank you. Thanks, everybody. Anyway, that's good to know. Okay. Thanks. That's it. Thanks.
Thanks so much for your questions. So we are going to be providing, we're at that kind of the end of time, but we are going to be providing the deck here on the TUBB4A.org website, along with the recording. So you will be able to reach out to CHOP for any clarifying questions you may have for individual cases. Just in the interest of time, we need to move on to updates and then close things out. I know a lot of people, everybody has places to go and meetings to get to. So thank you, everyone, so much for joining. We did have a couple of updates for the Kinslow TUBB4A Foundation. As you know, you guys, we are a new foundation as of this year. We launched at the end of February, and we have grown our board to include Michelle Olson. She is our Director of Patient Engagement. Many of you know her from over the years. I know that she's been at a lot of the events and a very involved member of our community, and so we are so excited to have her on board. We also have Kristen Wrangler, the Director of Finances. She has a long background in banking, and we are looking forward to all of her contributions to help us get everything set up the way it needs to be. And then Ashley Jaron is our secretary. Her daughter is newly diagnosed. We all met up in Boston, and that's what this photo is from. And we are so excited to have them on board. We definitely want to have the involvement of the community to make sure that like this level of contact with CHOP, with Synaptics, we want to facilitate it. We want you to be able to advocate for your kids, to have all of the necessary information to go out to your local doctors and be able to advocate for your kids for whatever treatment is coming available. So I'd just like to say welcome to Michelle, Kristen, and Ashley. All right, I'm going to pass it over to Michelle Olson to talk about Caregivers Corner.
Hi, everyone. I'll be quick for the sake of everyone's time, because some of us probably have kiddos to go care for. So on the Facebook and everything, so my son is Caden Richardson. So if you're wondering, I'm the same person. But like a lot of you guys, so my goal and passion is connecting with other families. Excuse me. So we can all feel a little less alone and create that sense of community. We all know, living in our different perspective parts of the world, that it's challenging, it's lonely, amongst many things. So something that I have been passionate about is it's going to be the Caregivers Corner. It'll be up and coming, so keep your eyes posted. Basically just collaborating with other foundations, some mental health professionals, obviously other caregivers too, just so we can create that sense of support and community to discuss topics, kind of like Francesca mentioned, like with caregivers, right? There's a variety of things that we do and see, and for us to be the best for our children, we need to be the best for ourselves. So I'll leave it quick. I'm going to send out some surveys. If you're part of this, we have your email to come up with some topics that are of importance and relevance to you guys. We want your intake. We want your participation to make this the most effective as possible. So look for those. We'll publish this on the Kinslow Foundation website, as well as I'll distribute through email. So just more to come. Just wanted to keep you guys aware that this is something that we're really passionate about. And I truly believe us getting together, being vulnerable, is going to strengthen our community. So just look for it. And I'm so happy to be a part of this.
Thank you so much, Michelle. Final item is we are going to be setting up Kinslow Quarterly Connections. It's going to be a new initiative to bring together our community every quarter. We do plan on holding sessions both in the morning and then later in the evening, so that and then rotating those to make sure that the majority of our population will be able to attend every so often. And from that, we would like to continue to develop these webinars, continue to advocate for your kids, implement additional strategies to organize for things like drug repurposing, which is on Kinslow's radar, is something that we're investigating pretty heavily. We are going to be open to topics, so we will be holding those every quarter. It'll also be just kind of an opportunity to connect and talk, right? This disease is challenging in so many ways, right? And growing and fortifying this community is extremely important, not just for those who are newly diagnosed, but those who have, been in the trenches for a long time. And those who have been in the trenches for a long time, I know that you have a ton of invaluable insight to provide to our community. So be on the lookout for those. And with that, I just want to thank Dr. Gavazzi so much for presenting today. So much new information and insights that we're excited to see. And thank you to Dr. Maya for joining from Synaptics Bio. The work that you and your company is doing to help our kids is amazing. is amazing, and we know why it got started. You know, so much credit to Michelle Tang for stepping up and doing what she's doing and building a great team. If there is anything, Dr. Maya, that our community can do to help support synaptics beyond participating in the natural history study, please let us know. We'll rally the troops best we can to support. And I know you've got a phenomenal advocate in Amy Sheridan Hill on the UK. We're happy to be that on this side of the pond. So please reach out with anything we can do to help. And I'm sure that goes for the entire community. And thank you to the community for joining today. I love the participation and so much more to come. Thanks, everybody. Have a great rest of your Friday and great weekend.
Thanks so much for organising. It was brilliant. Thanks, Daphne.
Thanks for joining,
Thank
Amy.
you.
We appreciate you guys.
Thank you very much.
See you soon.
Thank you.
Thank you.
Thank
Bye.
Yes,
Bye.
thank you very much.
Bye-bye.
Thanks. Bye.
Bye-bye.